Good afternoon and welcome to today's webinar, Back to School Update, Comprehensive Approach to Athlete Brain Health and Concussion. Thank you for joining us today. My name is Barbara Chabner. I'm the Director of Education and Outreach at the Brain Injury Alliance of New Jersey. The Alliance is a nonprofit organization with a mission to provide education, awareness, prevention strategies, advocacy, and support for those who have been affected by brain injury. I would like to remind everyone that the BIANJ will be holding its annual 5K run, walk, roll for brain injury awareness on Saturday, October 8th at 3 locations, as you can see on the screen: Saddle River County Park in Paramus, Bradley Beach Boardwalk in Bradley Beach, and Laurel Acres Park in Mount Laurel. Information can be found on the BIANJ website. We encourage people to attend, make teams, donate. It'll be a fun time for everybody. So now just a few housekeeping notes before we begin the presentation. Attendees' microphones have been muted. Feel free to have your camera on or off. If you have any questions during today's webinar, please type them in the chat. We will get to as many questions as possible at the end of the presentation. The webinar is being recorded and will be available for viewing on the BIANJ website. At the end of the webinar, a link for a post-webinar survey will be placed in the chat. We value your feedback, so you are encouraged to complete the survey. You must complete the survey in order to receive a certificate of attendance. Once you complete the survey, you will automatically receive that certificate. Our presenter for today's webinar is Dr. Matthew Mccarthy. Dr. McCarthy is a board-certified pediatric neurologist with additional fellowship training in sports neurology and concussion. Dr. McCarthy has expertise in managing acute concussion, post-concussion syndrome, and other neurological conditions in athletes of all ages and levels of competition. He specializes in using an active and individualized approach to symptomatic treatment and rehabilitation after concussion to ensure a safe and efficient return to school, sports, and other activities. As a sports neurologist, he is focused on long-term athlete brain health and promoting safe and lifelong sports participation. In addition to his role at Summit Health, Dr. McCarthy serves as a neurological consultant to several local high schools, colleges, clubs, and professional sports teams. I'm pleased to welcome Dr. Matthew McCarthy.
Thanks so much, Barbara, for introducing me and for having me here to do this webinar today. Let me just see. Okay, so no disclosure. We'll be talking about anything specific treatment related or any disclosures related to any of the content of this talk. My name is Matt McCarthy. I'm a pediatric neurologist originally, but then did additional fellowship training in sports neurology with a sort of specific focus on concussion. But I get the question about what is sports neurology. So just to sort of like review what that field entails. The main thing is it's treatment of neurological injuries from playing sports. So a lot of that is brain related. So concussion, the traumatic brain injury, but also peripheral nerve injury is a part of it. Another big part of it is just treating neurological symptoms and neurological disorders in current athletes and former athletes. Additionally, there's also an aspect looking at the neurological and just sort of overall health benefits of sports participation and exercise. And then finally, this is something that's been relatively newer, but people looking at like the neurological component of athletic performance. This kind of came out of the idea that after people had neurologic injuries from playing sports, in the rehab back from it, we're using specific techniques to train them back to sort of playing condition. So the idea of can you train that to begin with without an injury being there to sort of like improve neurological performance. So that's a sort of relatively newer area. So I'm going to be talking about a bunch of things today, but one slide to just sort of get some sort of definitions up front. And so I like to look at all of this from sort of the perspective of athlete brain health overall. And so this would be sort of like the course of a person's life. The time that they're playing sports and sort of like most active in sports for most people is in that sort of like early part of their life, and that's sort of like the early third. And so during that time when they're engaged in sports, that's when it's most common for an injury like concussion to occur, although it can occur from all kinds of different causes. But concussion here, the definition, is a temporary brain injury that's caused by brain movement. So it's basically a biomechanical force that's transmitted to your brain that causes brain movement, leads to a temporary disruption of brain function, but that's something that should happen and have a recovery over the course of days to weeks and completely go away. Post-concussion syndrome is another a term that's used commonly. A lot of people are changing from using post-concussion syndrome, using some other things. I've heard people recently calling it persistent post-concussion symptoms, persisting symptoms after concussion. They all mean the same thing, but that's basically when symptoms are continuing after the concussion is healed. So that sort of short-term change in brain function is now gone, but there are multiple interacting causes that are sort of leading to continued symptoms from that point forward. That's something that can last longer than the course of the concussion, but it can last for months to years. So anytime you're hearing about somebody who had a diagnosed concussion and they're beyond that initial sort of days to weeks range, that's typically where you're thinking of post-concussion syndrome. And for me, the most important thing is long-term brain health, right? That's just sort of like maintaining that person's brain health over the course of their entire life. And so in this talk, I'm going to refer to all three things. We're talking about concussion, post-concussion syndrome, and that long-term brain health aspect too. And I'm going to approach it a little bit from a specific approach, viewing it as a sort of athlete sort of through the course of a season. This stuff I'm talking about will also apply for people who are injured unrelated to sports. But as the framework, I'm going to be talking about sort of in the athletic population, since that's sort of the main area that I tend to see people from. But first, I'm going to start off talking about a little bit baseline testing. That's sort of the idea of gathering information before a season starts. But during the course of that season, concussion can occur. So that's sort of like the next thing I'll talk about, the definition of concussion. How's that diagnosed? How is it then managed to get people back into their activities? Finally, I'll talk a little bit about the diagnosis and management of post-concussion syndrome, when there's sort of a diversion from that normal recovery and you have that prolonged course. And then the overall lens that I sort of view all of those things through is sort of that long-term brain health one. So at the end, we'll sort of tie it into some of the ideas about long-term brain health. First thing to talk about baseline testing, getting somebody in before a season starts, before they're going to go play a sport or do an activity with a risk of head trauma. This has been around for a long time, the idea of a baseline test. If you can get the a snapshot of how the person's brain functions before an injury, that should help you in diagnosing the injury. It's a great idea, but sort of in theory, it's been difficult. I get asked all the time, sort of, what's the best baseline test? Is it something you can really test people's baseline brain function? And the answer is it's a lot more difficult than it seems. The most important question that when parents ask me what baseline test is the best test, the most important question is just asking, if my child or if I were to have a brain injury, where would I go to be treated? That's the first most important question. Because number one, the baseline information you get should be something that's going to be useful to the doctor that's going to be managing the concussion. So you want to take information that they will be able to use in the sort of management and diagnosis. Ideally, concussion is a purely clinical diagnosis. There's no specific test for it. So there's no specific test that's going to make that diagnosis, no specific test that's going to tell you when the concussion that the person had has completely healed. It's all clinical based. So it should involve a detailed neurologic history, detailed exam. And there's not really a single test that can be used. A lot of the baseline tests are sort of neurocognitive tests, balance tests, vision tests. Those are fine things to use, but they shouldn't be the sort of core basis of that baseline that you're doing for a person. It should be sort of focused mainly on sort of a comprehensive exam and sort of detailed history. So a lot of times when I've seen baselines being done, it's really just sort of like a single test that people are getting to kind of check that box. A lot of times that information is not particularly useful, just gets kind of filed away, they check the box, they did it. And it doesn't even end up being very helpful in terms of diagnosis and management. To that end, this is a recent study from a few years ago. They have a huge, through the NCAA and the Department of Defense, there's something called the CARE Consortium. It's a bunch of, it's all the military academies and also a bunch of Division I college athletic programs. And so they basically were looking at retest reliability of all of the common concussion assessment tools that have been used as baselines. So they had baselines in all of these athletes. They do it before the season, after the season, before the season, after the season. And they were looking at some balance testing, neurocognitive testing, symptom checklists, paper pencil cognitive stuff, some visual tracking exercises. And they were looking at, do these values change or are they stable? Can they be used as a baseline? And essentially the takeaway was that most of the measures fell well below any level of clinical utility. The NCA summary on it was that none of the tests that they were using as baselines were reliable for clinical interpretation. So those tests are not going to tell you yes or no for sure. What they found was that from test to test with no injury in between, the scores were going up and down for pretty much everybody. So you couldn't really think of it as a stable baseline. So when I do brain health baselines, I do them in office typically. So there are cases where I go out to teams or to schools and do them, but it's really focused on neurologic history. Is this person somebody who has any, at this point, recurrent symptoms that they're having? Do they have any relevant comorbidities that sort of overlap with the symptoms that can be seen in concussion? Any history of brain trauma or head injury in the past? Family history, medications, educational history, and then doing a general neurologic exam, but some focused concussion-specific things, focusing on eye movement, balance, coordination, and then occasionally in specific instances, there's a role for some supplementary testing, depending on that person's background, depending on their history, depending on the sport they're playing, depending on what level they're playing at. And so that information, it's not just sitting there and sort of like, if the person comes back to see me for a concussion, I'm comparing it 1-to-1, and that's the only way I'm making the diagnosis. There's a lot of ways to apply that information. The number one thing is, and I think the most important reason for doing those baselines is, it screens for a lot of things that I find in the populations I'm testing, undiagnosed and untreated neurologic or psychiatric conditions. I see tons of kids with sleep difficulties, headaches and migraines, anxiety, other mood disorders, ADHD, musculoskeletal problems. But these are things that, like, you can recognize, you can give that person advice on preventing and treating those things, and you can start a treatment plan with them. So that's probably the most valuable area. Next, it does help with sort of that sideline evaluation of acute concussion. When you see somebody who's been injured, knowing what they're like at baseline, what their history is, can help you in sort of determining exactly what's going on. It can help you confirm the correct diagnosis and also help you with guiding their return process when you're managing their concussion. And then on the long-term side, it helps for monitoring sort of any ongoing problems and issues that you might have in the background. So things that might be related to sports participation, that sort of are developing over the years, things that might be unrelated to it, but it helps you keep sort of track of things going forward. And I think the sort of other important thing is to have ongoing concussion and brain health education. Most people get a lot of the information they know about concussion, either things they saw on the news, things they read somewhere. A lot of people, it's firsthand experience. They or someone they know had a concussion or brain injury, and that is the way they got information. But sometimes that information is really outdated. So much of the knowledge we have now has come out very recently, and it changes all the time. So getting an update and having that discussion and being able to answer questions is a really important part of it. And so when you're just taking kids and putting 20 to 50 of them in a computer lab at once and having them take a neurocognitive test, you're not really having any other applications for that. So they go back and play their sport. Hopefully they don't have any injuries, but that's something that's sort of on some frequency. We should be sort of rechecking, right? Kind of reestablishing baselines. Depending on the sport, depending on the age, depending on the preferences of the person, but it can vary anywhere from yearly to every few years. So then instances where somebody is playing a sport and a concussion is suspected, it's an extremely difficult diagnosis to make for a bunch of reasons, but there's 4 that are sort of the main reasons that I think concussion is such a difficult diagnosis. Reason 1 is that not all brain pathology or all brain injury is going to cause clinical effects. So we know this from sort of every single part of neurology. People have tumors, strokes, MS plaques in areas of their brain that cause no clinical effect. It's only seen incidentally because somebody does an imaging study and you see that there's that area that was injured or that tumor is in that area, and it's not causing any clinical effect. So with concussion, there's sort of 2 thresholds. There has to be enough impact or force that causes that brain movement that crosses a specific injury threshold to cause injury to that person's brain, right? To cause that underlying change in brain function. But then there has to be enough injury in that specific person to cross a symptom threshold that it causes enough symptoms that they present with that clinical presentation and they're diagnosed with concussion. There are people who will get diagnosed with more concussions. It doesn't necessarily mean that their brain is more susceptible to injury. It may mean that they just have a lower symptom threshold, right? There are a lot of reasons people have that, but the most common one I see is migraine. People with migraine are very sensitive to getting headaches and a bunch of other neurologic symptoms. For them, it may not be that the severity of injury is worse, right? Their symptoms might be worse just because they are a lot more sensitive to those symptoms. So paying attention to both of those as important thresholds you have to think about when someone's coming in to be evaluated after a head injury. There might be people who get hit over and over and over and over in the head. They may be having injuries, but they may have a symptom threshold where they're not producing any symptoms from it. That's not necessarily safer or better. I actually worry more about that person than a person who very easily gets symptoms. The second reason it's really difficult is that even if somebody is hit and takes a significant force to their head, not every neurological effect you're going to see clinically has to be due to concussion. There are a bunch of other things that can cause those same kinds of symptoms. Right, so just like that impact can cause the injury to your brain that leads to the symptom of concussion, you can have that same impact or force affect other things that lead to other symptom triggers that can cause mimics of those same concussion symptoms, right? That's a really long, non-specific list of symptoms you can see with concussion. Many things besides concussion can cause them. Some of those things can be triggered after a head trauma. And that doesn't have to be together with concussion. That can be on its own. So reason number three, even if a person does have a concussion, it doesn't mean that every symptom they're feeling is caused entirely by the concussion. It can be partly from concussion, partly from something else, or even some of the symptoms entirely caused by something else. And so what I always tell my patients is your brain is very difficult to injure compared to other parts of your body. There's a good reason for that, right? It's very well protected because it's very important. So if somebody gets hit hard enough that we think it caused enough force to cause their brain to move and shake, that amount of force is almost always going to affect some other things, right? And so this is an example of that. So if you're seeing this person, there's certainly enough force that they're getting hit with that you would expect their brain could move, that you could have a concussion from that. But this is somebody who I'm also going to be looking at their inner ear and their ear as a potential area where they'd have some problems, their jaw, their eye, their teeth. And if you see how the head moves, definitely their neck, right? So all of those things are feeling that same force. If you have something that's affecting somebody's inner ear, their eye, their jaw, their face, and their neck, it's going to produce tons of symptoms from that will overlap with concussion symptoms. And they may not even have a concussion and still have a bunch of symptoms that would be listed on that same list of concussion symptoms. And finally, the fourth reason is there's not any diagnostic test for concussion. It's purely clinical diagnosis. It's not going to show up on imaging, a blood test, a computer test, balance test, a vision test. And so it is really sort of a detailed clinical evaluation that is the only thing that's going to lead to that diagnosis, but there's never 100% certainty. So what is the injury and concussion? Right, that change in brain function, it's not structural. There's no bleeding, there's no bruising, there's no swelling. I'm going to go really quickly through these slides just to sort of go over the general principles, but it's a change in brain function that has a neurometabolic basis. So that force of shaking and movement causes some underlying changes in depolarization and ion movement across membranes that eventually leads to an increased metabolic demand to reestablish that membrane potential. So it's basically just an increased energy demand. So this is sort of a graphic representation. This is animals, but basically the head impact was here. And over time, you see increases and changes in all these sort of metabolic measures. At the same time, this is those same animals. This is measuring their blood flow to their brain. There's a decrease in blood flow acutely post-trauma. And so what you end up with is this increase in energy demand happening at the same time that there's a decreased energy supply. So you have an energy mismatch. You have more demand than there is supply, and it leads to overall brain dysfunction. But it's not a specific area of the brain. It's not like you can point to one spot and say, like, that's the injured spot. It's an overall change in brain function. Your brain's normal function is to form networks, different parts communicating together in order to process information. And so concussion is a network injury. It's basically like a slowed down Wi-Fi network or a slowed down cell phone network, right? So those same communications that have to be made between different parts of the brain to process information just aren't happening as quickly and as effectively as they normally would. And so it leads to that person noticing a change in their brain function. As a result of that, the list of concussion symptoms is really long and kind of non-specific because our brain is involved in so many different functions, but generally it's broken down into a few different categories. There's a lot of cognitive and sort of mental status related changes. You can have physical symptoms, mood effect, sleep effect. But concussion is a projection, right? That list is only used as a sort of guide of the possible types of symptoms that you can have with concussion, but every person's brain functions different normally. So if you have this injury happening to this person, that change in function for them might lead to a clinical course that looks like this: the type of symptoms, the amount of symptoms, the duration of their symptoms. Same exact injury, identical amount of injury, identical concussion to a different person's brain. That brain functioned differently. That change in function for this person might lead to a completely different set of symptoms in a completely different time course. So it's a really individual process because it's that change in function. So because of that uncertainty in making the diagnosis, there's no specific test. And because of the variability in the presentation, it's been proposed that concussion should be something we talk about in terms of how certain we are about the diagnosis. And so this has been proposed from several years ago, but to think about it as a definite, a probable, or a possible concussion. So you're taking that clinical evaluation, you're looking at the mechanism, what actually happened, right? There has to be a mechanism. Where did the person get hit? How did they get hit? With how much force? And then the clinical effect. What are their symptoms? How are they evolving over time? What is their exam showing? And you're trying to look at that and try to figure out how certain am I that the concussion is the cause of the person's symptoms. So with definite concussion, that'd be somebody where there's a clear mechanism that you can definitely expect would have caused brain movement and caused that kind of injury. And the clinical effect, the timing of the symptoms, the type of symptoms, the evolution of the symptoms, the exam findings all seem to fit with concussion as the most likely cause of the majority of that person's symptoms. That doesn't mean that somebody who you don't have to think about other things. You still want to check that they have any other things contributing, pre-existing conditions, other things they might have had injured. But in those people, you're fairly certain that concussion is a part of the cause of their symptoms. With a probable concussion, that's where one of those things might be off. Maybe the mechanism isn't so clear. It might be a mechanism that you don't think is enough force to cause brain movement, to cause a concussion, or it might be a mechanism that's better for causing a different type of injury. Or the mechanism seems good, but the clinical effect, the timing or type of symptoms, the evolution of those symptoms, the exam findings don't quite add up to being a slam dunk for being concussion. So there's a list of things you're thinking of. Concussion's still near the top of the list. You think it's probably involved, but there might be other things that you think are causing some or even a lot of the symptoms. And then finally, a possible concussion. That's one where both the mechanism and the clinical effect don't quite seem to be clearly indicating concussion. In those cases, you're still considering concussion as one of the possible causes of symptoms, but what you're saying is that you think there are some other things that are more likely to be causing those symptoms. And so this is something I talk about with patients and with families. But at the end, it matters how you're treating it. Anybody who I think has a definite or probable concussion, we're going to treat that as though concussion is present. In the situation of possible concussions, you have to take it one at a time and figure out what are the specific things I think are going on. Are there resources to sort of monitor this person more closely, to sort of have a specific plan that we can do for this person? So these are sort of case-by-case basis. And so talking about those other things that could be causing the symptoms rather than concussion, this is something that's often missed, right? People go into an urgent care, their pediatrician's office, even many concussion clinics, and sort of automatically assume that if they hit their head and they're reporting those symptoms, it must be concussion. But in many of those cases, the person is not concussed. In many of those cases, the person is concussed, but not all of their symptoms are necessarily from the concussion. And so knowing about what are the sort of concussion symptom mimics that are out there, and there's tons. This is not an exhaustive list, but I see a lot of neck muscle strain and neck sprains, post-traumatic headache, sort of an induced headache from getting hit in the head, not necessarily from brain injury, occipital neuralgia or other peripheral nerves that can be affected by trauma, vestibular injuries or vestibular disorders that come after trauma, anxiety or panic attacks, diaphragmatic spasms, so getting the wind knocked out of you, underlying migraine, dehydration, heat exhaustion, jaw injuries, orthostatic hypotension or other things like POTS, injuries to the eye, sleep deprivation, deconditioning, both cardiovascular and neurologic deconditioning can sometimes mimic symptoms of concussion. So it's an extremely long list. This is important to know about because there's been extensive research into misattribution with concussion. And so this is from 30 years ago. But basically, they took people who had head injuries and they gave them a symptom questionnaire. There's 30 symptoms, and they basically said, like, do you have this, yes or no? They were asking about current symptoms. And then they gave them a separate survey of the same symptoms and said, rate, yes or no, did you have these prior to your concussion? So they did this to people who had a concussion, and they gave that same list to a bunch of people who had no injury at all. And they just said, like, fill this out. Do you have these symptoms at baseline? And so in the control group, these are people who didn't have a brain injury. They were reporting really high levels of some of these symptoms. So as many as a third of them were reporting some forgetfulness. But a lot of the symptoms people were reporting at baseline. If you ask people who were diagnosed with concussion to estimate their prior to concussion, did you feel any of these things? That number is significantly lower, right? There's a statistical significance between those groups. So it seemed like once the person was diagnosed with concussion, their estimate of whether they ever felt any of those symptoms before the concussion was altered. Similar thing, this is more recent. This is that same CARE consortium. This is NCAA athletes and military service cadets in the military academies. But they had over 12,000 cadets and over 18,000 student athletes, and they gave them preseason Scat symptom evaluation. It's basically a similar symptom checklist, but this is rated 0 to 6 on a bunch of different symptoms, possibly concussion. And this is at baseline. It's basically asking them, like, at baseline, do you feel these things? They looked at the percentage of people in each of the groups that was reporting enough symptoms that would meet the ICD-10 criteria for post-concussion syndrome. And so at baseline, without any injury at all, these are healthy young people. In the student athletes, it was between 10 and 20%, depending on gender. And the cadets was, 18 to 27%. So a significant number of people at baseline in a healthy population who was really active was reporting enough baseline symptoms that they could potentially be considered as concussed. And so the takeaways from this are, number one, after somebody has an injury diagnosed, we tend to underestimate the rate of premorbid symptoms, and there tends to be a trend towards attributing those symptoms to the occurrence of the injury. And the second, concussion symptoms are completely nonspecific, extremely common even in healthy populations when they're at baseline. So the symptom screening is really just that. It's a screening. It's meant to sort of look at, like, let's have quickly an estimate of like what kind of symptoms this person's having, but it really involves going much deeper than that to try to figure out if it's coming from concussion or not. The other thing is, a lot of the symptom scales are very binary, like yes, no, I have it, I don't have it, or like rate this on a severity scale, 0 to 10, 0 to 6. I tend to ask symptoms on a scale that asks about function. So I ask people 0 to 3. 0 not being present. 1 is it's present, but wouldn't notice it if you were distracted. 2 is present, you notice it, but it's not interfering with any of your activities. And 3 is it's enough that it interferes with your activities. But I actually like this scale better because it gives me a little bit of insight into how it's actually impacting that person on a day-to-day basis. Because some people will tell you they have a 6 headache, but it doesn't interfere with their activities, right? That's more important for me to know. So diagnosing the concussion, very complicated, very difficult thing to do. But if you do diagnose someone with concussion, what does that management look like? How do you treat that person, get them back into their activities, back to their usual activities, sports, school, work, regular life activities? So this is a little bit outdated now. This is sort of an old diagram, but I was always thought of as sort of 3 stages of that sort of a concussion management. The first is an acute rest stage, can actually be relative rest, and then finally graduated exertion. The acute rest was initially thought of as sort of like is needed for healing. You have the person kind of like do brain rest, cognitive rest, physical rest. They avoid activity until symptoms recover. Relative rest was sort of starting back in a symptom-limited way, right? So as tolerated, ramping up their usual activities. And then finally, the graduated exertion was once symptoms have gone away and they're tolerating their normal activity, you kind of guide them through a step-by-step return back to their specific sport activities as a way to sort of confirm that the injury has resolved. And so we're going to talk a little bit more, but on this slide, the biggest things that have changed over the past almost 10 years are, number one, that acute rest phase. We recognize more and more that brain rest isn't something you need to do, isn't something that's even possible to do. It's not helpful for healing. It's not something that promotes recovery. It's something that may help with symptom control. It may help with symptom management. So it's good for comfort, but it's really only very specifically early on. Beyond that, it's been found that actually the acute rest can be detrimental. So that sort of section there, kind of updated. I'll show an updated version of this at the end. Should be much shorter, and some people don't even actually need to have any acute rest. That relative rest can be the first stage they started. And the other thing that's changed is symptoms being completely gone before starting to do physical activity. More and more, it's not only seen as a treatment for concussion, but or as a necessary thing for clearing a person from concussion, but it's seen as something that's a treatment for concussion. Earlier return to physical activity is something that is consistently seen as a sort of necessary part of recovery. Concussion is something that you don't just wait for it to go away. It's something that's very actively managed. And so right from the beginning, right, when you suspect a concussion, it's important to immediately remove people from play. The reason for immediate removal from play is that you're not trying to decide if the person has concussion or not. You can't make that diagnosis in that moment. What you're trying to decide is it safe for that person to continue playing, right? And so just because somebody gets pulled out to be evaluated doesn't mean they have a concussion. It's not a guarantee that that's the reason they're coming out. It's determining whether you think that person needs to be checked out before we can safely have them go back in. But they found that earlier removal from play and immediate removal from play Number one, it avoids the risk of additional injury and not just concussion. There's tons of evidence that musculoskeletal injuries are more common when people continue playing while they're concussed or when they return too early after concussion. But they've also found that people who are immediately removed also tend to make earlier recovery and end up returning to play quicker. The next thing that's important is getting in as quickly as possible with a concussion specialist. And so a lot of times people find that's a difficult thing to do, right? Finding somebody to get in who has expertise, who can see you. I keep my schedule flexible throughout the whole year so that I can fit people in usually on the same day or the next day if there's a suspected concussion, so we can get an immediate plan in place. But first we have to confirm what the correct diagnosis is. Is this concussion? Is it not concussion? What other things might be going on? But we want to start appropriate management right away. And so a lot of times in the past, people were just sort of like seen, told, just rest, give it a week, give it a couple of weeks, don't do anything, stay out of school, stay out of sports. That is not beneficial. That's not helping the person recover, but oftentimes it actually hinders their recovery. And so it should be right from the beginning something we have a lot of sort of specific management strategies about. So the number one thing is anticipatory guidance. So the first visit I have with somebody for an acute concussion, most of what I'm talking about is this is what the usual recovery course from the injury is like. This is what you can expect. This is what is within the range of normal. And letting them know that early mental and physical activity is safe to do. When it's done properly, it's actually really beneficial, right? So learning that that's okay to do. Telling them that brain rest, not only is it not possible, it's not helpful. And then starting to talk about their symptom management, right? While the injury is recovering, the most important thing you can do for somebody is help their symptoms be better managed. And so working on things like treating their headache, working on their sleep, neck, if there is any neck injury, having a plan for any cognitive symptoms and the return to cognitive activity. You want to also assess for any pre-existing things, right? Any prior injuries. So do they have things like any prior concussions? What was the recovery like from those concussions? Is there anything that could be left over from those injuries that might still be going on and affecting them now? Do they have any headache or migraine history, any ADHD, mood problems, learning difficulties? And you want to start doing education and talking about long-term concerns. What I find is if you ask kids or if you ask people who are coming in, like, are there any specific concerns you have? The answer is almost always yes. So you want to start doing that education and discussing some of those concerns, because if they have those concerns and you're not addressing them, they will continue to have that worry hanging over them, and it can impact their recovery. So you want to talk about the long-term risk. You also want to start talking about prevention strategies, right? Looking at how it happened in this case, and then trying to talk about the risk going forward and ways that you might lower the potential for another injury. And so this initial phase is really important. And the biggest reason it's important is there's a ton of potential for placebo and nocebo effect with concussion. So most people have heard of placebo effect. That's when somebody has a positive effect that is based off the patient's positive expectations and beliefs about the state of their health in response to a specific treatment. Nocebo effect is the opposite of that. It's basically a negative effect that's produced by a patient's negative expectation or beliefs. And so fascinating stuff. It's not like a made up thing. Placebo effect, nocebo effect, it's actual real like physiologic, biochemical, physical changes happening based on that patient's expectations or beliefs. They've even done trials. They're doing a lot of trials now with open label placebo, where the person is told up front that you are taking the placebo, and it's still found to be effective. And so the New England Journal had a recent overview of placebo and nocebo effects, which was really fascinating if anyone's interested in looking at something like that further. But they looked at it with concussion. They found that there's a ton of potential in concussion care for nocebo effect, right? There's a lot of negative expectations. There's a high potential for misattribution. There also is a really significant societal nocebo. Concussion is something that's been in the news. It's been on television. Can't watch professional sports or professional sports coverage at all without hearing stuff about concussion and CTE. There have been a lot of public health campaigns. And now at this point, it's a very common diagnosis that almost everybody will have some anecdotal experience from friends, from family, from people they've seen firsthand go through it. So there's a high potential for nocebo effect if you're getting that sort of negative expectation set up from the beginning. And so that's where the anticipatory guidance helps. You can talk to them about what the recovery is supposed to be, but avoid catastrophizing thought processes, right? Tell them like, if this symptom happens, that could be normal. This is why it might happen. You want to explain the underlying injury and the cause of the symptoms from the injury, but also other potential things that could cause symptoms. That minimizes fear for a lot of patients. But then you're giving them some options for treating it. You're talking about actively managing it, right? You want to give them sort of patient-controlled things, not just resting and avoiding things, but saying like, if you feel this is what we can try to do for it. So it gives them a little bit of sense of control. And then having close follow-up. Anybody whose symptoms are worsening, anybody who's having continued symptoms that aren't coming back, it shouldn't be something where it's like, oh yeah, they're coming back in a month, just wait and see me then. It should be sort of like, come back sooner if you don't think this is, progressing as you expect it to, and let's kind of get on top of it and sort of not let it linger. And then talking about their goals, what are their fears, what are their long-term concerns? A lot of the times that's underlying all of it. And so having that discussion early can really help. Going back to activity, return to learn, is obviously a part of returning to activity. It's definitely, for kids who are still in school, a priority. But it has to be differentiated, the return to activity versus the return to risk of injury, right? So returning to learn, you're not posing any risk of additional injury. I've never seen somebody injure their brain in a classroom. I've never seen somebody injure their brain doing schoolwork using a computer. I've definitely seen a lot of people get increased symptoms though, right? So it's recognizing what is the risk of actually doing that activity for symptom worsening versus what is the risk of actually causing injury. And so for return to learn, the goal is always to get that person back into school activity as soon as possible, but you want to prioritize their comfort and you want to prioritize managing their symptoms. I don't want people to fall behind and miss a lot of work because that will cause unnecessary stress. That will kind of set them back and kind of put them in a hole. But I also don't want to have them feel like they're pushing through to the point that they're feeling miserable to keep up with everything. It's trying to strike a balance. And so in the ideal world, people wouldn't have to miss any days of school and wouldn't have to fall behind in school. From the beginning, we should have individualized academic accommodation plans. Things like extra breaks, modifying their workload temporarily, postponing things, giving them extra time to finish, modifying some of the sensory exposure to lights and sounds, crowds, providing copies of things that for days they may have missed. So you want to provide support during the period where they're symptomatic, but allow them to continue attending school as much as possible and working their way back in a way that minimizes their stress. And so concussion management teams can help with that, right? There's a bunch of people at the school, from the athletic trainer for the sports teams to the school nurse, to the guidance counselors, to the teachers. And that's in cooperation with their medical team, right? The range of people who are seeing concussion is all over the place. But it should be something where there's an open communication that everybody's on the same page about. And always being mindful and proactive about the stress part of it. The goal should be to not do anything that's causing undue stress during this time when a person's recovering. The other part of it is returning to play, right? Returning to sports and physical activity. There are a ton of specific protocols that have come out over the years. The main goal of this is to challenge the person with physical activity, with increasing complexity, increasing intensity, as a way to challenge them to see, does it seem like their brain is functioning normal again, right? So it's not a specific treatment. What you're trying to do is sort of throw more and more difficult challenges at them to make sure that you're confident before you clear them to go back to their full activity, that you have evidence that the brain injury seems to have recovered. And so it's not a one size fits all, but in general, it starts with more cardio exercise. So light and steady state exercise. You can add more high intensity stuff, add some interval training. The next step up from that is agility. It's where you're adding more complex movement, direction changes, rotation, changing body position, adding some weight. The step up from that is sport specific training, right? So starting with individual drills, adding more sport environment, adding some limited contact. And then finally, when relevant, contact, right? Providing an opportunity to do full contact in a controlled practice setting before you're exposed to it in the game setting. And then finally, the last thing is game participation. But just because a person did a full contact practice doesn't mean that they're done with what they've done. You still want to watch that person. They're going back into a game, checking in with them, watching them, making sure that like afterwards, there's nothing else that came up, nothing that seemed to worsen. So it's an ongoing evaluation to ensure that it's safe. This is something that should be completely individualized though. So the person shouldn't be doing exercise and activities that they've never done before as part of that recovery process. It should be relevant to their sport, their position, their level of training. So you need to fit these categories to what that person specifically does. What I see done wrong a lot of the times now is there's a protocol at a specific school or for a specific sports team, and it's like you do a bike and then you do a treadmill and then it's the same for everyone. But you might be dealing with people who've never done a stationary bike exercise in their life, who've never run on a treadmill before, who've never done any weight training. You want to find out what is this person usually doing to train and find stuff that fits that you can challenge them with. You need to allow enough time after each level to sort of see these symptoms develop, to evaluate how they're doing. And it should start and be in parallel with the return to learn. It's not something where it's one then the other. It's not you return to learn and then you can start this. These should both be things that are started early on and should be going hand in hand. And so this is an update of that that same slide from before, looking at sort of the injury onset and recovery. So that first stage, the acute rest, right? There's still a role for it potentially. Really, it's in the first couple of days. There may be benefit symptom-wise from doing less activity and from resting. Beyond the first couple of days, you do not need to do that. It's actually not helpful. It's probably likely to prolong your symptoms if you do rest for too long based on deconditioning. But not everybody needs it. Some people will start right away in a relative rest. Relative rest is where you're doing any non-contact activity. So that's social activities, school, cognitive things, using screens, daily activities around the house, even like physical activity and exercise. And it's based on symptoms. So anytime you're resting or avoiding, it's not because of safety, right? You're not doing activities with risk of head trauma at this point. You're resting because of comfort, right? So you can modify and rest based on comfort alone. And then finally, that graduated exertion, even this, probably needs to be updated. The graduated exertion can start much earlier, even like the day after, the couple of days after. But in general, you're sort of progressing through that cardio, agility exercises, sport-specific training, and then finally introducing that element of contact as a way to sort of confirm that the person's injury is completely resolved and recovered. In concussion, on average, that injury is going to be days to weeks. On average, about 7 to 10 days. So as this injury is recovering over 7 to 10 days, the goal is to be having somebody moving along, ramping up their activity, managing their symptoms, so that by the time the injury is recovered, you're not just starting that rehab process, that return to activity, you're sort of near the end of it and getting sort of ready to be sort of cleared for everything right away. In the past, what had happened too much is people were resting and resting and resting, so they were really deconditioned, really behind. If they were waiting for that few weeks to go by where things were feeling better, and then when they started to do that rehab stage, they were really deconditioned, really out of shape. So there was a lot of things impacting their ability to do it outside of the injury itself. All right, so somebody with concussion who, hopefully it's a smooth process back into sports, but every once in a while people will develop post-concussion syndrome. The estimates are anywhere from like 10 to 30% of people diagnosed with concussion will go on to develop post-concussion syndrome. So how do you diagnose that? How do you recognize that as opposed to concussion? And then how do you treat it? So again, this is the same kind of picture, right? Concussion should have this single phase peak and then recovery. The symptoms should be present pretty immediately. It usually peaks over the first couple of days, gradually recovers over somewhere around 7 to 10 days. And so typically the symptoms from the injury will do the same thing. They'll peak early on. Typical concussion recovery is going to be within a couple of weeks. Often when that doesn't happen, the trend that you see most commonly is the symptoms start to recover, but then sort of plateau and then become this up and down sort of like ongoing symptom course. And so it's not just the amount of time. It's not once you hit 10 days, it's automatically post-concussion syndrome. Everyone's recovery is different. It's a little bit related to the time, but it's also related to the pattern, right? Are they the same symptoms? Are some of the symptoms getting better? Now there's only a few of them left behind. Were they all progressing and improving, but now there's sort of this up and down pattern? Some people won't look like this. Some people from the beginning will have sort of like a plateau of symptoms. Some people will even be getting worse at first. But anytime that pattern isn't a single monophasic recovery, that suggests there's other stuff going on. And so it's important to distinguish whether you think something is concussion versus post-concussion syndrome, mainly because the treatment is different. Concussion, there is a certain amount of time that has to go by for the injury to recover, but that should happen, doesn't require any specific treatment to make it happen. Post-concussion syndrome will not get better unless you identify what's causing it and do treatment for the underlying cause. And so the first step is just to take an extensive history, do an extensive exam, and make a list, right? So these visits I have are often very long. But some of the things that contribute, the unplugged syndrome, that's sort of like people who've been resting in a dark room, not doing any exercise, really deconditioned in every way. Underlying migraine or headaches, mood issues that were either pre-existing or have started after, issues related to sleep, neck injuries, ADHD, extremely long and broad list of things that can contribute. Once you make that list, you sort of have all these things that you think are going on. They're all overlapping and interacting in some way, right? So somebody's sleep being affected can affect their mood. Somebody's mood being affected can affect their ADHD symptoms. Their ADHD might affect their sleep because they're spending so much time working to sort of catch up on stuff they've fallen behind on because they've been resting and sort of not doing any schoolwork. So these things all interact and overlap. But the long term is these things start to interact and start to build up. And the actual symptoms you end up getting from post-concussion syndrome are greater than any of those individual parts alone. And so you have this big thing that often gets tied back to the concussion, when in reality, there's a bunch of different elements causing it. And so to treat it, you have to separate those things out make a list of what they are, and then come up with a specific individualized plan for treating all of them, right? So unplugged syndrome, you can come up with a specific plan. For mood-related symptoms, there are specific things you can do. For migraine and headaches, for ADHD, for sleep, for cervical issues. And so coming up with a specific plan for that person's problem, I've found a ton of success with people getting completely back to normal, resolving all their symptoms that they were having. Okay, so finally that last part, long-term brain health, right? So anytime I'm seeing somebody at a baseline visit, anytime I'm seeing somebody who's been concussed and I'm diagnosing or treating their concussion, anybody who I'm treating for post-concussion syndrome, I'm always using those as opportunities to talk about that long-term brain health component. And so this is just an example from the neuro baselines, but I talk about all the long-term brain health considerations, even at those baselines, right? So we're screening for underlying diagnoses or even sort of like precursors, some tendencies. A lot of the things that you would screen for, things like migraine and headaches and anxiety and ADHD, are things that are diagnosed in childhood years, during the years people are playing sports. I find a lot of times I'm picking up on things that are sort of like predictors of eventual evolution of things like migraine and ADHD, but you can be more proactive about it. Monitoring for any chronic symptoms, right? Seeing if things are getting better, getting worse, coming up with plans to manage those chronic symptoms. Monitoring for evidence of brain dysfunction, discussing risks and benefits going forward. So every time I'm seeing somebody for baseline, I'm not just talking about the risks of the sport they're playing, but I'm also talking about the benefits. What specific benefit are they getting? There's a ton. Their annual dose of force, it's a lot different if you're somebody who's doing one season of basketball versus somebody who's playing football, then wrestling, and then playing lacrosse, right? Like, and then some people are just playing for their school team. Some people are playing on club teams. They're playing year round. And so like more and more we're recognizing it's not specific injuries that are the major concern. It's the number of repetitive head impacts. And so what's the annual risk you're putting yourself at? What's the future exposure to those types of impacts? Are you planning to play just for fun through high school? Are you planning to play in college? Do you want to make this something you do professionally? You're going to do this the rest of your life. And then constantly re-educating, updating things, coming up with specific plans for each person. So this is specific to that discussion about the risks and the benefits. So this is a survey from, it's about 20 years old now, but they took a bunch of US high school students, over 14,000, and they had them fill out this survey. It's called the Youth Risk Behavior Survey. So as part of that, they asked if the people played team sports. So about 70% of the male students who completed the survey played at least one or more team sports, and a little bit more than half of the female students played one or more team sports. And so they looked at whether playing a team sport was associated with any of these healthy or at-risk behaviors. And basically what they found is both the male and the student and female students, participation in team sport in high school was associated with lower rates of basically every risky behavior. So things like smoking, drug use, weapons, suicide. And so this is the data for the females, but these odds ratios, anything less than 1 means they were less likely to do it. Anything greater than 1 means they were more likely. So they were less likely to do all these things except for regular vigorous exercise. So they were eating more fruits, eating more vegetables, exercising more, not smoking, not using marijuana, cocaine, or other legal drugs. And the same thing is true for the boys. The only one that they were more likely to do was regular vigorous exercise. All the other ones, they were far less likely. So tons of things about playing sports are associated with healthy lifestyle choices. And then finally, just on the sort of specific topic of like neurodegeneration, right? Something that people, especially with football, has come up over and over again, like the long-term neurodegenerative risk. This is from the Lancet Commission on Dementia Prevention, Intervention, and Care. So a couple of years ago, they put together this big report about how to prevent and treat dementia. And so as part of it, they identified 12 modifiable risk factors that they thought accounted for about 40% of the dementia risk worldwide, right? So the other 60% of risk for dementia is either things that are not modifiable, like genetic risk factors, or potentially things that are modifiable that we just don't know about, haven't identified yet. But with these 12 things, I think about 40% of dementia risk could be prevented. And so when you look at that list, it's a bunch of things. The majority of them, though, are things that sports would be participating in sports and physical activity would be protected against. So minimizing diabetes, hypertension, reducing smoking, reducing obesity, frequent exercise, reducing depression, maintaining frequent social contact, avoiding excessive alcohol. So all these things we know are potentially protective from participation in sports. Also on that list is preventing head injury. So the only sort of one that would be associated with sports potentially that's in the negative is preventing head injury. But relatively speaking, it would seem like participating in sports is a very, very beneficial protective thing. So they looked at what percentage and at what stage in life. So these are some of them they thought were sort of earlier in life, middle of your life, later in life. And they tried to quantify like how much of the risk of dementia is accounted for. So traumatic brain injury, they thought was about 3%. So that means that 37% of the risk of modifiable things for later life dementia were things that were unrelated to head injury that you could potentially modify. And a lot of them could be potentially prevented by participation in things that would sort of emphasize physical activity and exercise. That's the last part I had. I wanted to leave some time at the end for questions, but wanted to just do sort of an overview, kind of touching on all those aspects.
Great. Thank you so much, Dr. McCarthy, for all that great information. We'll take some questions now. If anybody has a question, you can pop it into the chat. And we have a couple of minutes that we can spend answering questions. No questions? I think I saw earlier that someone might have had their hand raised. So whoever that was, if you had a question, want to put it into the chat, you can certainly answer it. So someone is asking if there are resources available.
Resources about sports concussion?
Yes. Any, I guess, general resources about sports concussion that you would recommend?
Yeah, so the Brain Injury Alliance has, I think it's still, the website is, you can still get their sports concussion I don't know if it's .com or .org.
If you actually just go to the BIANJ.org under the concussion tab, there are resources there.
Yeah, it's the domain used to be sportsconcussion.com, but Brain Injury Alliance has a website with a bunch of resources, a page specifically about sports concussion. On the Summit Health, I work at Summit Health out of Florham Park. My website, like if you look at my provider name, there's a bunch of there's some videos I've made and some overviews, question and answer type things that I've done in the past. Those are two things I refer people to most often.
Okay, great, thanks. Another question, is there any insight on ADHD meds during the acute phase?
Yeah, so in general, it seems as though people who do not have ADHD, who are having concentration and focus symptoms post-concussion in the acute phase, the trade-off of sort of side effect risk with those medications tends to not be beneficial. So it's not something like if somebody doesn't normally have ADHD, has an acute concussion, you're starting that medication in the acute phase for treating those specific symptoms. There doesn't seem to be enough benefit to offset the risk of side effect. In people who have ADHD pre-existing, it's known that if they're on medication, continuing that medication during the acute phase after injury is usually beneficial for them. So I usually recommend if somebody's already taking medication for their ADHD, that after concussion, even though their symptoms may increase, should continue to take their medicine throughout the recovery process. But I don't typically prescribe that medication for an acute onset of difficulties related to the concussion. In some instances, if a person who hasn't formally been diagnosed with ADHD, but they're seeing me after a concussion, having a lot of difficulty with concentration and focus through the evaluation, it seems as though the underlying diagnosis of ADHD is an appropriate one. It just hasn't been made yet, hadn't been recognized. There are times where I will start medication sort of going forward, but it's usually not in the immediate acute phase after concussion.
Okay, and sort of along those lines, somebody's asking if ADHD can actually be caused by concussion.
Yeah, they've done studies on both ADHD and migraine to sort of see if there's a causation effect. The problem is that the peak age of diagnosis for ADHD tends to be in childhood, as does the peak incidence of concussion. So it's really hard to know. There does not seem to be a causation effect, meaning it doesn't seem like people with concussion tend to develop ADHD symptoms. It seems actually the opposite is true. It seems that ADHD is a predictor of getting concussed. A couple reasons. One, and these are just sort of like proposed reasons. One is people with ADHD, part of that ADHD is often the hyperactive side tends to be hyperactivity and impulsivity. And so there's a thought that if there's distractibility and impulsivity when you're doing not just sports, but just activities in general, there may be a higher chance of a fall or a collision or getting hit. So the mechanism is more likely to happen to a person with those traits. The other part of it is related to that symptom threshold. So if you look at the symptoms on the list of concussion symptoms, at least a quarter of them are things that are common in people with ADHD. So they are predisposed to having those symptoms. So it does make them more likely to potentially have symptoms after a head trauma. So that just makes it more likely that they will be actually diagnosed. And so there's probably more evidence that people with ADHD are more at risk of being diagnosed with concussion than there is evidence that people with concussion are at risk of being diagnosed with ADHD later.
Okay, great, thanks. A couple more questions. So someone is asking if you have any suggestions about how to get a college sports coach to take concussions seriously.
Yeah, so this is something that's always a problem. The culture, a lot of the sports, the culture has changed significantly. And for the majority of sports, there's more focus on injury prevention and recovery, and sort of the injuries are taken a lot more seriously. That being said, the coach should never be the person who's interacting first with athletes about injury, right? You'll see sometimes it'll be like a college football game, and it's like there's a player down injured, and like the coach runs out on the field and is standing over him. That's the last thing you want. You don't want the coach to stand over the kid when they're injured, because they're not going to be able to answer the question honestly. If there's a coach standing there, it's almost like intimidating them. You want that to be done exclusively by the trainers and the medical staff, right? That communication shouldn't have to go from the player, the athlete themselves directly to the coach. It should go from the athletic training staff, the medical staff. But that's a tricky one. It's been a culture change that's happened gradually, and it starts in sort of youth football, but you still hear things all the time about sort of. I mean, there's a thing yesterday, like it was like I think it was Nebraska, like the head football coach was bragging about how much the players were vomiting during practices. It's like, that's not what anybody's goal should be. So the idea is just sort of like having more information out there, having more awareness about it, right? So like groups like the Brain Injury Alliance, stuff that I'm trying to do, talking to people about this type of injury as much as I can. So in my experience, I've found a lot better. People are a lot more receptive to it now than they used to be. I even see it on sidelines. Like it's way more common for me that a coach is pulling a kid out or a teammate is pulling a kid out that no one else recognized anything was wrong with. People are self-reporting their symptoms more. So I think that overall the culture shift has happened to a great degree. In instances with specific coaches who are sort of have that sort of like old school kind of mentality, it's really important that there's someone else that's sort of in between in handling that sort of medical specific stuff.
Okay, great, thanks. It looks like we have two more questions, which I think we can get to. It's just 2 o'clock.
Sure.
So if people can stay on for another couple of minutes, we can get through these. And Chris, also, if you could put up the survey link so people can take that as well. So we had a question: what kind of cognitive remediation is best for sports concussion?
Yeah, there are certain specific cognitive therapies. The best approach that I've seen is to immediately start returning back to activity, especially cognitive activity, social activity, routine. The best way to treat it is to prevent it from becoming an issue, right? So many people will have cognitive symptoms after concussion, but typically those are really acute in the first couple of days, even some people like the first few hours where it's most present. You can avoid a lot of the longer term cognitive effects after concussion with an early rehab process where you keep that person engaged in their normal activities, on their normal sleep pattern, exercising, socializing. And there's nothing that anybody's that I've seen, sort of available as cognitive rehab that tends to work as well as that person's actual real life activities, right? In therapy, you can sort of like approximate and challenge them in specific ways sometimes. But generally, I like to have people do stuff that they're used to doing and that they like doing, because they'll be more engaged, they'll be more used to it. And so my approach is usually to have them start right away with going back to their normal life activities. Definitely, there's modifications and sort of like ability to take breaks and things like that that you want to, advise them on. But getting them on a early sort of rehab sort of track with cognitive activity is usually more effective at preventing it than anything is later on for treating it and remediating it.
Okay, great, thank you. We have someone here that said, thank you for the great presentation. We have a question that says, you spoke of doing a comprehensive health brain history as a baseline. Many schools still use impact testing. Can you comment on impact?
Yeah, impact was that was the neurocognitive test that was used in all the studies that found there was like no retest reliability. And so impact tests I find to be not helpful at all for diagnosing concussion. And as a baseline, they're basically just sitting kids in front of a computer for 20 minutes and then they just file it away and they have like a report that no one usually looks at. It's not that it's not, right, those tests are testing cognitive function, but they're not specific to concussion at all. So if you take it at a different time of day or in a different setting, or if you had more sleep, or if you didn't drink caffeine one time and you drank caffeine the other time, or you were distracted because you were thinking about something else, or one time was in the summer and one time was after an injury, or you had a headache one time and you didn't have a headache the other time you were taking it, every one of those things is going to impact how you do on those tests. You're sitting in front of a computer doing a bunch of sort of like cognitive tasks. And so none of those things are specific to concussion. When it gets interpreted, though, every single person who takes it and gets, sort of like less than their baseline or has a score that's lower than the standard range, it's interpreted as though it's a sign of concussion. So in those baselines, those people who took them without any concussion, without any symptoms going on, well, as far as post-head injury symptoms, their scores were all over the place. There's no sort of like, this is a known baseline. So even if you were concussed, there's not necessarily any guarantee that score is going to be worse or better based on the injury. And so the reason that it exists as the sort of like standard baseline test is because it's extremely easy to administer to like a mass amount of people with minimal effort. So you can just put all the kids in a computer lab and have them take it, or a lot of times you can have people take it remotely. They just take it from home. You send them a link and they take it. And so it like satisfies, you check the box that like we did baselines this year with no one having to do any actual effortful work. And so for that purpose, it's great. For actual like being able to use the data for something and being able to help with concussion management and diagnosis, it's pretty, I've never used it clinically. I've used it as part of research studies. I've used it when people bring it in from, sort of having it done at their school or from the outside. I've never once found it to be a helpful piece of information though.
Okay, thank you. And then we just have one sort of comment here, question about if someone falls down the stairs and I guess hits their head as a child, from that, could you develop a learning disability? So could that kind of an impact cause something like that?
Yeah, it's hard to know. I mean, definitely there is, from concussion, by definition, you should not. And that should be a sort of like transient effect where that change in brain function sort of comes and goes. With a more significant brain injury, right? So there's a whole bunch of different structural changes that can happen that could potentially have longer lasting effect that could impact learning. So with concussion, you should not. So in terms of screening for it, you want to make sure there wasn't a more significant injury. So things like structural imaging or neuropsychological testing, and there's a bunch of ways to measure brain anatomy and brain function that you can look at if there's any sort of like long-lasting impact. But from a concussion, it shouldn't be persistent and cause like later problems. It's not something there's a ton of like specific research in, right? It's fortunately something that doesn't happen too often. But so there's not a ton of like specific data or research on it. There is always thought that like the injury occurring during important stages of development may have a greater impact. In my personal experience, I've seen that most of the time kids recover much faster than adults. If you look at the data, it shows usually that kids have longer recoveries, but it's usually just because kids, people tend to take a really cautious approach from just pure like how quickly they're back to feeling better and like able to do activity. I find that kids bounce back much faster after the injuries than adults do. But still, people tend to have a lot more caution when approaching kids. So the actual data ends up being usually that the kids are cleared from the injuries later.
Okay, great. So that was our last question. So the survey link is in the chat box, so we'll just leave it up there for a little bit longer. And I want to thank you again, Dr. McCarthy, for sharing your expertise with us today. I think we answered all of the questions. If anybody comes up with any questions later, you can send me an email and I can forward it over to Dr. McCarthy. One final reminder to complete your post-webinar survey so that you can get your certificate of attendance. And thank you again, everybody, for attending, for your thoughtful questions. And thank you for, again, Dr. McCarthy, for your time and for all this great information. We hope to see you at future webinars. If you have any suggestions about webinar topics that you would like to see, please send me an email. I'll quickly put my, information in the chat. And with that, we will conclude today's webinar.